Just give people a second to make their way in and then go ahead and get started. So we have lots of time to talk to this fantastic panel that we have here and to each other. So this is meant to be one of our more informal, casual sessions where we just take advantage of the opportunity to gather together and brainstorm and talk about challenges faced and lessons learned and hear from our experts about kind of how they approach these questions. Really appreciative of this chance to talk about digital accessibility. I'm going to do brief introductions for our speakers or panelists, and then ask them to sort of add anything they want to add in terms of introductions, and then really just want to open it up for questions and topics that are on everybody's mind. So I encourage you to turn on cameras. This is like a more casual one. You can raise hand, put comments, questions into the chat, or just unmute, because again, we want this to be a more casual part. So thrilled to have Dr. Andrea Graham joining us, Assistant Professor in Chief of the Division of Implementation Science in the Department of Medical Social Sciences at Northwestern University Feinberg School of Medicine, where she is the co-director of the Center for Behavioral Intervention Technologies, or CBITS. Her program of research focuses on the design, optimization, and implementation of digital, mental, and behavioral health interventions. She applies human-centered design methods to design digital tools that meet users' needs and implementation plans that support the integration of digital interventions into practice. And she has a particular interest in disentangling core components of digital interventions that improve engagement and effectiveness, as well as collaborating across sectors to accelerate the translation of digital interventions from research into healthcare systems and community-based organizations. So very excited to have you here with us today. In addition, thrilled to be joined by Dr. Karen Fortuna, who is an assistant professor of community and family medicine and co-founder of the Collaborative Design for Recovery and Health. As an international volunteer collaborative of patients, community health workers, peer support specialists, caregivers, policymakers, and payer systems, the collaborative uses community-based participatory research approaches to facilitate the development, evaluation, and implementation of tools to develop a workforce of lay providers with lived experience, expertise to support similar others through peer support and evidence-based practices. Dr. Fortuna works with community members from vulnerable populations such as older adults with multiple chronic health conditions, caregivers of people with dementia, and people with disabilities and behavioral health challenges. Currently, Dr. Fortuna serves on the National Advisory Board of the National Academies of Science, Engineering, and Medicine Standing Committee on Primary Care and Achieving Whole Health. And this role allows her to contribute to advancing comprehensive healthcare solutions that integrate physical, mental, and social health for vulnerable populations. So thank you so much for joining us and being here today. So I will start us off with a question, but really encourage everyone to just jump in and raise the thoughts that are on their mind. So first, I actually like you to each add anything to the introductions that sort of maybe express your tie to this topic and any disclosures or conflict of interest that you want to share and those kinds of things to get us started. And in that, if you could also, note your tie to the topic and kind of what digital accessibility actually means to you. It's a relatively broad term that could mean a lot of different things. So, Andrea, do you want to start us off there?
Sure. Thank you for having me. And it's just a treat to see all these, anyway, the conference and to all be together. And to have the time to chat together. Nothing that I would add further to my bio. Thank you for the lovely description. But I would say, to me, digital accessibility, I don't want to say it's a loaded term, but I think as Bethany phrased it, it's means a lot of different things. So one is, I think of like literally who can access these tools. So across different communities. So have done some work in rural areas that have really opened my thinking around what it means to have access and when people can access these tools and the literal like how in terms of concepts of Wi-Fi connectivity. And then I also think of accessibility as, I think we want all of our things to, as we think about the words on the screen and the colors, and I think that has really important components for people's learning capacity. And then there's actually aspects. So I do a lot of my whole work is in research trials. And so sometimes accessibility concerns come up that we hadn't thought of. For example, our coaching protocol is mainly through text messages. And sometimes people will say, like, I don't feel as comfortable with texting. I would prefer email. Or financially, that's a hardship. I would prefer email, for example. And how we grapple with some of those components of accessibility when we think of research trials as sometimes needing to be more controlled, and how we can expand in those ways. So that's been it like has really pushed my thinking in those ways in a positive way. And I've not that I'm glad that those things have happened, but that I was
Right.
positively challenged to think through those creative solutions and how we think about designing future tools to be as accessible as possible. I think the one other thing I'll add is that I've worked a lot with startup companies through SBIR, STTR grants. I don't have conflicts of interest in those ways, although I'm currently funded on an NIH grant with a company, but have no investment in the work. But beyond in the company, I do have a lot of investment in the work. But here I get fired on this call. And so I say that because we often think about companies also needing to think about, as we think about digital and scale, accessibility comes up, and where we can devote resources to being really prepared for scale and different kinds of access has been something that as companies we grapple with when it's a startup and they don't have a lot of resources to deal with. And so is it available in multiple languages? Those are important questions that often you hope that companies would have more money, and often it's that when it's a startup, they actually don't.
Yeah, for sure. For sure. Thank you, Karen.
Hi, everyone. Karen Fortuna is professor of community and family medicine. And so when I think about accessibility and technology, I've been actually thinking a lot more around artificial intelligence and how that actually can impact accessibility. And so thinking about like human factors in the design of technology, that many individuals who may be disadvantaged may not want to engage in certain technologies. And so while it is potentially accessible, right, maybe using SafeLink phones or Assurance Wireless or whatever it may be, there may actually be challenges related to engagement. So how much is it around access? Yeah, maybe we can fix access by providing people tools and then, working with people to improve health literacy. But the question I've been coming to lately is about engagement in these types of technologies that may not align with the values and belief of particular populations who may have been historically marginalized. Yeah, so Bethany, sorry, I just saw you unmute.
No, I really appreciate that. Can you maybe, I think you're making such an important point about the link between access and acceptability and maybe assumptions people make that those are the same thing, and that they're not. And where are you seeing that there's those divides happening where people may think they've solved a problem, but actually the engagement issues are still there?
Sure, yeah. So actually, I love that question because we were actually just talking with patient partners at another event, and we were talking about remote patient monitoring, right? And so these types of things, which could be a little device maybe or Bluetooth entered into a person's home, and they could monitor potentially, you can actually monitor symptoms of depression, you can monitor agitation. I mean, so many different types of things you can do with that. And so here we have this, reimbursable, we can get this technology into your home and train you how to use it. A patient partner was mentioning this, and he said, good luck getting my dad to use this because he doesn't trust the government. And this was a gentleman who is from West Virginia, rural West Virginia, where there was a large influx of opioid use there. And so there's a lot of distrust within that population. And as he said that, actually, a tear came to his eye in this very public presentation because he doesn't think, even though his dad has access, that he won't use that remote patient monitoring.
And what do you think could shift that?
Well, I think what could shift that, based really on the science of when we build technologies like what Dr. Graham is doing, is working with patients and community partners as we build new technologies, because maybe there is an opportunity to develop remote patient monitoring that maybe doesn't include AI, right? And so learning that at the beginning, rather than, spending hundreds of thousands of dollars and you deploy it and people just don't want to use it. We did that in one of our studies, and we work in Harlem with people who have diagnosis of serious mental illness and chronic health disease, so they're considered
Mhm.
dual eligible. We
Yeah.
all older adults. We built an app. We spent hundreds of thousands of dollars. We delivered it, and they said to us, "Karen, I don't want to use this. Just let me talk to somebody over the phone." So we totally just ditched the app, and then we had the intervention delivered over the phone, and we got great outcomes, right? So,
Yeah.
um, and we could have saved all that money and time if we incorporated our colleagues who are patient partners at the beginning.
No, that's a great example. Tanvi, do you want to jump in?
Yeah, I really appreciate both these points that you guys are raising with like the balance between kind of community specific access and trying to build in a way that's like scalable and sustainable. And so I'm wondering, kind of as a overview, as you've worked across different settings or perhaps different intervention modalities, are there things that you think are like this is universal design and we need to put it everywhere? And are there parts of it that you still feel is really good to prioritize, like that customization and like personalization for the population?
Can you say more what you mean, like from an accessibility perspective? These
Yeah,
should be
like
table
for
stakes.
example, I could think about like the AI question. One way to make it accessible for a broader amount of people is to toggle, like build it in and then make it so that people can toggle it on and off. But that creates a layer of like, okay, well then someone like has to do the work to toggle it on and off. So sign up for a different population, automating that, like it starts in the beginning, makes it super easy. But that's a really hard question to decide when to do something like that. So I'm kind of curious how you balance that challenge of personalization and like scalability.
We will not be out of jobs. Because no, because I think you're bringing up it's a really empirical question, and it's like I don't know if I know the right answer. And there's a lot of I'm thinking of moderator analyses that would say under what context would that be really important. And on the flip side, I also feel intimidated at the idea of like needing a 5-year grant to answer that, right? How can we do fast science so that we could also answer that kind of a question? I don't have the solution to that, but I think it's fantastic. To your point though, what I was thinking also when you originally asked the question about what could be table stakes, one thing that came to mind is the ability for things to work across devices have felt pretty important, and yet it's very expensive. And so for those that may be familiar on the call, there's something called a native app where you download it from the App Store, and then there's web-based mobile apps where it's a website that can change sizes depending on where it is. And so if you build a native app that's Android and iPhone, that's very expensive, and that's suggesting that you've actually done both platforms. Some people just choose one. But the truth is, so there's trade-offs in all of that. And then the ability to also have it be mobile web responsive. So quite frankly, I think that is from being person-centered, as a term we now are using a lot of in this conversation, of like really thinking about what personalized needs are and accessibility, it would be the ability to be across devices. So some people could look on a tablet, some people could, and at the same time, there's the literal cost benefit of like, do you have the resources to build that? For those that are newer to the field of digital, it's cheaper to do web-based mobile responsive apps because it's really a website that changes sizes. So if you needed also on a shoestring budget, like a K award, that is a great solution. Or as a grad student, like those are important considerations. And maybe that's useful as proof of concept of some of the behavior change strategies or implementation strategies you might be thinking about with your tool that can lend you to then want to invest more subsequently.
Yeah, I think it's such an interesting trade-off that you're pointing to because it has all those benefits, and you lose the opportunity to integrate mobile sensing or some of the other things that you might want to do and certain ways of doing notifications. So it's like they're legitimate, like just trade-offs to be figured out there. Karen, did you want to add anything to that?
It's a question I've been thinking about philosophically, and I haven't come to a conclusion on it, because it is, how do you do that? And I like the idea of what our colleague was saying around, universal design, building it in a way so you can reach the largest audience, as a potential solution. And that's really as far as we've really come with that. But then how do you have universal design when you're working with different cultures? You can't at that point. So it'd be very cool if someone could build out some, AI. So you could just integrate that and then it's adapted. So anyway, just kind of being imaginative about that approach.
Yeah. And I appreciated the sort of comments Andrea made about going across platforms, devices, etc., because we do have research that suggests choice is really valuable for people, right? And so the more that we give them options rather than a one size fits all model, I think, yeah, I think in lots of spheres we're seeing that. We've certainly seen it in our own data where people who used a mix of whether it was tablet, phone, web-based, people who used a combo had greater engagement than people who used only one method. Now that may just be a sign of like their, they may not be that, there may be a third variable explanation tied to motivation that accounts for that, but it nonetheless points to like, yeah, it's not only a cross-person variation, it's also within person variation, because there'll be a time they're on the bus and want to use something and a time where they want it on their phone and then somewhere else. Can I go back to sort of an extension of Tanvi's question for Karen and Andrea to consider? I guess I'm curious to go back, sort of a variation of the universal design question, but a shift on that to ask, like, are there accessibility elements that you recommend should be standard of care, kind of across devices, and then other things that should be customized? So I'm thinking about like, the idea of like slopes at crosswalks were, people thought of as being really valuable for wheelchair accessibility, but then turned out to be really valuable for strollers and 8 million other, and so it became sort of a universal design standard of care. Whereas other features like might help one group, but actually would get in the way of accessibility for another group in terms of how, some of the color things, some of the size things, right, are beneficial for one community and not for another. So I'm curious, like, if you have thoughts about things that might be in that standard of care category, like the crosswalk example in the digital health space, or how you think about those issues.
So I can jump in here. So I've been working with the American Psychological Association around what are these standard types of issues around accessibility. And so those are published online, and I'm happy to share them here as well. And so certain things around accessibility is ensuring that the font size can be larger for individuals, offering multimodal ways to engage with the technology. So that might be audio, that might be video, um, those types of things. Having access in rural areas that may not have a large or good Wi-Fi, such as even northern New Hampshire at Dartmouth, where I'm at. Like some days our Wi-Fi is really bad. We can't even get on Zoom. And so that exists. And then also offering opportunities for people to call in and get support when they need it. So having a live help desk rather than, a help desk, because there are even some help desks online. And you're talking to an AI bot, and that's frustrating in that if you need some support and that's not the level of support that an individual needs. We also think about things around comprehension as well, even of the whatever interventions being delivered. And so delivering it in a way that uses things like single structured sentences. So you can improve an individual's or promote an individual's capacity to understand the information that is coming through the technology. And so we think about things like that as well outside of digital features.
This brought up so many points that may or may not be answering the original question. One of my favorite things I did, and I'm proud of this, is because as an academic, it felt really important to do, is we worked at the Center for Health Literacy at the University of Arkansas for Medical Sciences. There's other groups as well, but to do, to simplify the language of our intervention. So Karen, when you were just talking about that, like, and the reason I'm proud of that is also it helped me learn how to do that for myself, right? Use more bullet points, like breaking sentences apart, being really simple. And that's really relevant for consent forms. It's relevant for flyers. Like it's really relevant from broader engagement tactics. So it was useful for me to learn. It was a paid service, but it was really fantastic. But the other thing that all of this made me think about is accessibility. What we haven't talked about is also, well, we talked a little bit about the where, but like where people are getting access to these tools. So here I'm today also at a training institute for implementation science, the Implementation Research Institute. And we think a lot about sort of not just healthcare settings, so people get access to these tools, but can they get access in community-based organizations, online settings, like direct-to-consumer markets through employee assistant programs. I've started to explore, can we work with food pantries to get people access to tools who have food insecurity? And so part of this is also, another component is the literal where and how we, from an implementation science perspective, like how we would train the referring individual or the offering individual how to think about digital tools as well, and having that conversation. And Tanvi worked with me on a trial that we're doing just that with clinicians, and it's hard. It's hard to change people's behavior even at the one level up, quite frankly.
We've got a lot of questions coming into chat here, which is fantastic. Let me start with Stephanie's. Do you want to read that, Stephanie? Or I can do it.
Yeah,
Okay.
sure. I can read it. Yeah, I was wondering if any of you had suggestions or best practices that you've seen that works for clinicians that are using virtual therapy or remote therapy in contexts that it's harder to reach the communities, such as rural settings, lower setting contexts, lower resources contexts. Yeah, to ultimately to improve engagement.
It makes me lean towards the JAMA article that was published maybe 6 months or so ago around finding those populations that are disadvantaged have higher engagement in telehealth or virtual therapy using the phone. So there are some restrictions on that by state, and then maybe potentially by institution as well, needing to see a human as you're providing those therapies. However, that is what we know helps engage those populations. And so in some places, what they're doing is offering different approaches to allow people to engage through text, through phone, through video conferencing, and then through offering that preference. That's when they're able to get those higher rates of engagement. Dr. Graham, I'll pass it to you.
Thank you. And Stephanie, is it engagement as in getting into or staying in? And you'll probably say all of the above, but I feel like those are two different concepts too.
All of the above, unfortunately.
I think going back to an earlier point we were talking about is, also asking people what they would want. So if there's ways to, when people are presenting for services, so amongst people who would engage, like meaning maybe they came for one session, and then your point is how do you get them to come back? And so understanding, what would make most sense for them. And then for the places where you're looking to engage people, I think indicating, as Karen indicated, like the different types of modalities that could be feasible as potentially a strategy.
Thank you. And I'm so sorry, Sayatana, am I pronouncing your name correctly, or can you?
Yeah, sure. Cayetana. And I'm so sorry that I can't be camera on today. I apologize, but I'm very excited to be here. So yeah, I'm really interested about how participatory engagement may be changing with AI and right with these tools that frankly we're learning to use ourselves, right? We think about this big black box of this tech. How does this impact digital literacy, accessibility, what we tell the folks that we're working with? It just seems like it's a really exciting and frankly, really challenging place for us to be to make sure that the folks who we're working with are empowered.
Totally agree. But can you say a little bit more about your question? So when you say, I'm just looking on the side, like how we would actually engage end users in understanding that. I mean, to me, it's really impactful about transparency in this, but let me answer part of it and you'll tell us if I got it right or wrong in terms of what you were asking. So one of the neat things lately that I've been doing is working with some physicians at the Children's Hospital at Northwestern, where I work, who are interested in building these AI-based models, so prediction models for clinical care in the services that they're working in. I literally don't I'm trained as a clinical psychologist. I don't understand the words they're using. I don't know anything about their settings very much. But what I do know is about human-centered design. And we talk about that in terms of they build these models and then they phrase it as they die in the literature, meaning that how do you actually then have a clinician use this at the point of care? And so we're spending time talking about how they're engaging clinicians in design activities to really understand, like, what are these model outputs meaning, and are they willing to trust an AI generated model, like an AI based model that has machine learning? How do we build trust? What does that output need to look like in order to be usable at the point of care? And so I say that because I think that's part of, as we leverage AI tools, to me, that's really part of the design work we should be doing concurrently, is really understanding how users want that to be packaged to them, and the ways in which it goes well and could go awry. And I don't mean, there's obviously very serious safety issues in going awry, but an example we have is we have auto messages. That's not AI, but we have auto messages coming through. And so what we needed to do, and then human messages also coming through. And so when you write in, if an auto message comes, it's awkward if the user prior had already said it, like it can be a mismatched conversation. So we now indicate this is an auto message. Do people habituate and ignore those? Yes. And so that's another component. Now that we're live on that, but it wasn't until we were actually like in the field deploying that till we really realized some of those constraints. So ways in which we can do small tests of change and proof of concepts are really important for I think learning how users can react to those components, and where added swim lanes is the wrong idea. It's not to be constraints, but added supports can really come about.
Yeah, Dr. Graham, that's a beautiful answer. And that's what I was getting to, kind of like this idea of who are our stakeholders? Who are we engaging with to develop something? What information does everyone have? Are there any barriers to use, right? Like, again, if something's automated, do people say, oh my gosh, okay, I'm not paying attention to that? Or, for example, trust, right? Like clinician or provider trust in like a complex technology. And yeah, and then maybe even a use case with folks who, end users are our patients or our clients or whomever. How do we design products and services that they feel like they understand the tech enough to be able to say, hey, look, I'm in this beta and here's what I think works and here's what I think doesn't. So I loved your answer. I thought that was fantastic. Thank you.
Thank you.
And we're thinking, and we're going to be deploying around incorporating patient partners and building our AI algorithms and our prompts as well. I don't know what's going to happen with that. We haven't tried that before. And so it's an interesting empirical question. And so that's been our pathway, and very in its early stages.
I
That's
think
very
it's,
cool.
oh, sorry, go ahead, Kayan.
Oh, no, that was it. I was going to say I'm excited. And that's really cool to kind of bring the end user into prompt engineering and kind of all this space.
Yeah, absolutely. And just, I'm curious to extend that, Kaitana's question, because you talked, Angie, about like the mismatch kind of pieces and stuff like that. I think one of the other things that's on our mind is like when it becomes creepy. So there's the like transparency piece, but also the like personalization is great until it's like, whoa, this feels like you're like have a little too much information about me, and that starts to feel uncomfortable. So I'm just curious, like how you're thinking about that aspect as well.
I will say my research is not sophisticated enough to be there yet, right? In terms of, but I'm laughing and thinking about like, right, when we talk about it with our friends, some random yogurt, and now we get ads on Facebook for the yogurt. And but I must admit, I don't know enough in our own research sphere yet. But my guess is it's coming.
Yeah, and what we've been doing, no, I hear you. I smile too, because there's just something that, there was something with an AI bot telling someone in recovery that they should take a hit of meth so they could keep their job, so they can go to work.
Oh
And they
dear.
said, yeah, and they said it just came out in Live Science, and they said, I got you, Pedro. And so this was, this was a simulation, so that's good. It wasn't like real. So it's really fascinating. I think what researchers are doing now are doing simulations and then adding in large language model judges as well so you have that human component too. And
Right.
so That's what people are doing, and it's not only scientists thinking it's creepy, right? It is. I'm talking to patient partners as well, and so what we've done with peer support specialists, who we work a lot with, we asked them, hey, how can we include AI in the work that we do? And they said to us, well, you can't replace peers with AI. And I said, okay, no problem, I will not do that. But what can I do from an intellectual curiosity standpoint? And so we brainstormed some ideas, and one of which that came up was that we would create a virtual supervisor for peers. And so it would actually be used for professional development as they're delivering interventions that have an evidence-based practice. And so as they deliver, they're programmed through video on an app. It helps guide the peer in the actual delivery of an evidence-based practice. And so that's some early research that we're doing. Wrote a paper on artificial allies. And so we did a lot of simulation models around this fidelity adherent delivery. And so they were okay with that approach. But AI is changing so fast. That's the challenge, because what happens if all of a sudden we have a new AI model using generative AI as it's, learning, and then it, recommends using meth for somebody. So it's there needs to be guardrails in place.
No, absolutely. And that leads well into Cesar's question. Cesar, do you want to read that, or?
Sure, sure. I was just thinking, spinning off some of the earlier comments that Karen made about that participant who essentially told you, we don't want to use this. We just want to talk to people, and you guys did that, and then you got a lot of different results. So I was thinking about these concerns about because they mentioned distrust in government, for example. So I was thinking about these concerns about data safety and privacy that we all, from the evidence that we know, seem to be very important barriers to access for these tools. Especially, I mean, we don't hear that much or with that intensity from youth who are digital natives. Not in the work that I do, that is more um, dealing with LGBTQ youth who also have evidence of being more open to digital tools than other groups, but um, it's a constant concern, these data privacy and safety. So I was wondering if you guys could share some success stories, maybe, of how we could bridge those concerns and try to improve access to these tools, or maybe how do you think that would look like, bridging those concerns or addressing those concerns on data safety and privacy that we constantly hear from study participants.
I'm curious what you've done. Like, to your point about that, really important marginalized groups, what are some of the thoughts that you have, if you're comfortable?
I mean, again, and Tyler is here, and Tyler has been doing a lot of our work over the last couple of years. Um, we haven't heard that strong of those concerns from LGBTQ youth in the first place, but we have. And the way that we have been addressing that is disclosing how the data is going to be used, who's going to have access to the data, to the best of our ability, disclosing what will happen with the information once that, for example, they exchange interactions with our chatbot and those type of things. And um, those things seem to address their concerns to a enough extent that that participants are willing to either donate data, for example, when talking about social media data, or to participate and interact with our chatbots, for example. But I wonder about other age groups. I mean, I'm not used to work with, for example, older adults, who might have some of those concerns a lot more acute, and I wonder, how do people address those concerns to then have these participants using the tools? Because the lack of access to mental health services is for everyone, not just for youth, of course. So I'm very curious about that.
Yeah, we work with older adults, and our approach was not using these more sophisticated tools based on their, at least what they told us, their preference. And that's with a highly marginalized population. And I wonder too, I like the idea. I think one of our colleagues said you turn things on, you turn things off, right? Like you can share your data or you don't. And we did some an analysis of that, and people said if you do that, then I'll be more likely to engage. Um, but I don't know how that really exists in the real world outside of a scientific experiment. And so it makes me think that maybe there's an opportunity for some quasi experimental designs like in the real world. What is happening out there in the real world around this? Um, yeah, Dr. Graham, what do you think on that one?
Well, thanks both of you for sharing your thoughts. The I think there's two sides. One, not necessarily about data safety, but it did make me think about privacy and sort of clinical safety. You know, sometimes it's then we're not going to ask the PHQ-9 ninth item, and that feels sad. So for those unfamiliar, that means screening for depression, and that's a suicidality item. And so I think those are heavy conversations, right? In terms of like, okay, we have what would we do if people didn't want to share their data, or we don't have the ability to share sort of with the relevant clinicians or have a stopgap? And is that worth it? What, you know, sort of it's a moral, I think, consideration. To your point, Cesar, we do a lot with participants, and so that's not necessarily real world per se. But I think, of course, our consent forms are an opportunity, and yet we also know that's a very loaded, heavy document that not everyone's reading all the components of. And so I was really inspired a few years ago by Charles Jonasine, who talked about the work that he and his team had done to engage people pre-trial. And they spent a lot of resources thinking about how do you make people really informed about what they're about to sign up for. To your point about data sharing and those kinds of things, how do you make people really informed prior to even entering a screening tool? And so we've started to invest in some of those ideas around creating videos that explain some of those things, that people can learn more and feel more, ready to join the kinds of things that they need to join. And on the flip side, what we're missing is all the people who aren't joining because of the concerns that you're bringing up, right? So I think it's then how do we catch those people and find that? And I do think that's where, and I don't mean to just lean on human-centered design, those are important questions also that we can do of engaging people to say, like, what prevents you from coming in? Or if we were to design a tool, what is the way we can do it as safely as, like, what feels meaningful to you? All of the above. And the last thing is, of course, in the real world, when we download things online, we just hit accept terms and conditions. I mean, I've never invited a lawyer to help me look at the terms and conditions of anything I use. And I feel, I would like to believe that often academics are probably really thoughtful about some of those designs, maybe relative to companies. So it's an interesting bag on all of that. So I guess I end with, I don't know that I have the best solutions, except to continue to be as transparent as possible for folks. And then I love this idea of and proposals that have come about of how people can turn on and off those components, can have the ability to do that at any time, right? Like they can turn it on, they can turn it off at any point. That seems really important and powerful.
Mm-hmm.
I think there's also something that's really interesting about the power of the choice, regardless of whether people end up using it. So we had an on-off option for a bunch of different sensors for a recent study, and not many people necessarily say, don't use this, don't use that, right? Like, but knowing that they have that option, I think can be powerful for folks.
I think that also speaks to some of the
Yeah.
behavioral economics components
Totally.
of, is it opt in, opt out, and how we, you know, sort of leverage design behavior choice, you know, and that's important too.
We also got feedback from a group of users from the qualitative work of like that a group that had more privacy concerns, and it made us realize that we kind of had to have two versions of the privacy plans we made available. Like we had this sort of like highly transparent technical version that gave all the information for people who wanted to hear about SSL secure, blah, 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 blah. And then we had to have a translated version in the sense of like something I could understand that was at a much more accessible level. And so realizing that maybe both need to be in there so that people can choose. And then
I
the
love
other
that.
thing,
Have you published on that by chance?
I can share some information afterwards on
That's
that.
very
Yeah.
cool.
Yeah, it's not like published. It was just like part of our design, like feedback we were getting in design process. The other thing that we did was we convinced our IRB to let us change some of our consent forms so that because we showed them like research articles that said shorter consent forms are actually better for informed consent because people actually will engage with those rather than the really long ones. And so for some of our work, not all of it, but for some, we have like these like pop-up models. So like the basics of what IRB required is there, and then it has, how you've seen like a little question mark on something. If you want more, then you can get more information. But that way it's like, it's not all an 8-page document, even though there's 8 pages there for those who want it as a, you know what I mean? So not that that solves all of it, but those are some of the things we're playing with to try to like meet the different needs that we're hearing.
I have one more point, which is that talk about silos, and many of us often, so here I really drank the Kool-Aid around human-centered design, which I think stemmed a lot more out of computer science and human-computer interaction field. I recently was learning from a bioethicist, and that would be another person I think is really imperative to have at the table from the start. So, just Bethany, when you were describing like the shorter versus the longer version, what does it mean knowing people aren't reading the longer version, and yet it's who would, right? And at the same time, ethically, like where's the line? And of course, IRB's job is to protect the research subject, but in life. And so that's I think a perspective that's really also imperative that we continue to think through as useful for this work.
100%. Jacqueline, do you want to share your question?
Sure, and I want to kind of slightly modify it based off of what we've been talking about as well. But I'm kind of curious to hear everyone's experiences as to like how often are you considering accessibility or engagement? Is this at the beginning? Like how often is your team meeting? Are you meeting with all kind of interdisciplinary team members? So the psychologists on the team, the human factors, UI UX design folks, the coders. I'd be curious to hear how often you guys are meeting as a team when you're in the intervention development stage and while you're actively have, a digital health tool out to the public. How often are you getting feedback beyond just maybe in a research context as well about how quickly are you able to, integrate that feedback into your tool for participants?
We do ours at the beginning, and then we meet weekly if we're building tech. And then once we deploy, I'll have people on our research teams actually joining us as well. And so these people may have a diagnosis of schizophrenia, and we try to incorporate people who are also unengaged as well. And so sometimes there's people who engage a lot, and they're, what do they call them? They're like professional patients. That's what people say. And so, which is great and amazing. And I really enjoy working with them. And we try to also include them, but also people who, may be experiencing homelessness that may have even a harder time engaging, and make things flexible for them. And in those situations, sometimes we just do, sometimes people can't make those weekly meetings. We communicate through email. Similar to what we would do with other people and following the principles of the American Disability Act.
And you probably can tell my answer, but I'm going to say all the time, do I want to understand people's engagement and what they like and what could be, more importantly, what could be improved? So I would better phrase it as much as possible. And I have really come to understand we want to do things correct and as best as possible, but There's a term in human-centered design on MVP, minimally viable product. And I really believe in the importance of like go live. And there, you know, we joke on our research team that we're often building the plane as we're flying it. And obviously that's not safe in life. But here, I mean, in sometimes, to your point in the chat around prototyping, like sometimes you just literally have to go live. But what happens is once you go live, like it never works as you're expecting, or so much more comes up because we can only learn as so much at one point, and because technology changes. So it's actually like the whole life cycle of it all. Any way that we can continue to learn is ideal. And I do think the best learning is from, as Karen was describing, the people who are having a harder time. Like as much as I like getting positive feedback on the things we design, it feels good, but it's so much more powerful to learn. And I try really hard to phrase it of like, we want to know what we can do. I can't promise we're going to do it now because we don't have the budget person, you know, but what more can we do, and help really think big on what could be possible.
Thank you. Sadly, we are running out of time. We just have a few minutes left, but I'd love to sneak in at least one or two more questions. Freya, do you want to share your question? Can't turn on camera, so, or audio. So how can clinicians enhance engagement in digital mental health services for patients facing cognitive or physical disabilities, such as those living with Parkinson's disease? And full disclosure, Freya is a member of my research team, and we're trying to collect data with patients with Parkinson's and Huntington. So I think she has a particular reason for asking that one.
I think the only answer to, I don't mean to sound like a broken record, but I think it's, we have to learn from those individuals what their needs are. And love that you all are working on that, right? Because it sort of opens so many more doors to thinking about people who have digital mental health needs that could use services, but those are literal, like physical disabilities change the game. And this comes up, so in this partnership that I was mentioning that Tanvi and I have been part of, it's, you know, the clinicians have brought up, what about people with high cognitive decline? How much can we think about offering a digital tool? And so I think that is really where it speaks to simplicity. And Kieran, I don't know if it was your group or colleagues, oh, maybe it was in Vermont, similar town, but not the same place. But they, you know, did a full no word app. I mean, that's beautiful, right? Like what a cool concept for people who don't speak English. And, you know, and so I do think aspects of, you know, understanding like what is getting in the way of their use. If you have Parkinson's, my father-in-law actually has Parkinson's. And so it's like shaking, right? That would be hard to read a phone if it's shaking a lot. So are there ways to make that audio? I don't know if that would be better, although he's hard of hearing to I hear him on the recording. But you know, it's like, I think that's spot on of like trying to understand like what are their needs and designing around that, but trying to keep it simple. So we don't need to go all the way to the bells and whistles to start. What are the simple things that we can do to help make that experience better?
I will say too that like one of the things that, you know, it seems like a clear take home message of like talk to the people you want to work with, you know, and always and often and at all stages. And one of the things that became clear to us, particularly with the Parkinson's work, some things we'd thought of in advance tied to like font size and things like that, because of the movements, a back button ended up being like super important because people would be more likely to push something they didn't intend to, and so wanted to be able to move, you know, so like that wasn't on our way. But the other thing that came up was like when they would ask for certain accessibility features, they were often experts on like how to connect with other third-party apps that already had those things. And so not everything has to be created in-house. If you can get that interoperability, then, which is hard, right? Like then you can actually take advantage of what's already been created. So
I think a lot about, and I'm so glad you brought that up. And then Karen, I didn't mean to cut you off, but just that I've often thought about how groups have spent billions of dollars making tools that I won't ever be able to do. And are there ways that I can actually like combine that, bring that to people in ways that really work for their needs? That's such a beautiful thing to not need more resources, right? And that's fun to have learned it from the individuals themselves of what they found creative.
I love that. And I'm glad that people are thinking about this because we all want the same opportunities to engage in technology. So similar to like a TV or something, we all have the same opportunity to have entertainment or whatever the TV may be for you, video games or whatnot. And we're developing an app around identifying preclinical neuropsychiatric disorders. And so that maybe before there are some really overt symptoms that a person is experiencing. And so we've gone a few pathways, and one of which is really working with collaterals in the technology and actually about engagement, because you have to use the technology to have this screening. And so rather than people who may have, fear around some challenges that a person is having, you work with the collateral to get them to download the app or whatever it may be. And so that's how we think about it. We really think about this human technology interaction, and that we are not, solo in this world. And what does that mean? And so it could be the daughter or son and whatnot. And so we haven't deployed this in the real world. And so, 6 months, follow up with me and we'll see how it goes. But again, it's before there's overt symptoms.
Well, we are going to take you up on that and hope that next year you'll come back and we can continue this
Yes,
conversation.
ma'am. Yes, ma'am.
That seems like a perfect note to close on. Everyone, please join me in a huge thank you to Andrea and Karen for thinking through these difficult issues together with us. And I think it's a work in progress for everyone. And so really appreciate the chance to just be in community and talk about all the challenges and opportunities in this space. And thank you all for the fabulous questions, and hope to see you in just a few minutes at the members meeting. So thank you, everyone.